This is Dr. Max Kammerman for the Fundamentals of Sports Medicine covering ankle anatomy. This lecture will cover anatomy as it pertains for the clinician who is interested in learning more about clinically relevant anatomy so as to better evaluate and treat patients both athletically and for the weekend warrior. We're going to work from the most profound or deep aspect of the ankle, from the bones, and expand outward into the tendons and ligaments of the ankle as we go through this. Please follow us on the web, on Twitter, Instagram, Facebook, or hit us up on email at fundamentalsofsm@gmail.com. Again, we are the Fundamentals of Sports Medicine. Now, moving on from the ankle, the ankle joint itself is comprised of 3 bones. We're going to begin over here on the right side of the screen so as to better discuss this, but the 3 bones that comprise the ankle joint are the lateral fibula, the tibia, and the talus itself. Now, the major points of articulation of the ankle are through the talus and tibia, as seen here by this bluish articular cartilage. And the relevant things to know about the ankle is that the ankle is a hinge joint with the second greatest range of motion for the hinge joints in the body. The ankle itself, or the ankle joint itself, is often called a mortise joint, and this comes from wood joinery, where the mortise is the piece of wood which forms a cup or shape into which a tenon or dome can be placed. In this way of speaking, we can see that the talus, as the tenon of this joint, enters into the ankle mortise. And the reason I'm bringing this up is because often in imaging or when describing the ankle joint itself, one will hear about the ankle mortise. It's important to know where that comes from, I believe. Now, moving on, it's relevant, of course, to understand the bony anatomy generally of the foot, and for that we'll look over here on the leftmost image. Again, I'll identify the major landmarks as we see the lateral aspect of the fibula, the tibia, and the talus itself. Moving distally from that, we have 2 bones which articulate off of the calcaneus and talus in this area. We have the lateral cuboid bone and the medial navicular bone. The navicular bone, of course, being the keystone or major load-bearing bone of the arch of the foot. Distal to the navicular bone, we have our 3 cuneiform bones, the lateral, intermediate or middle, and medial cuneiform bones, before going into the metatarsals and the proximal, medial, and distal phalanx bones of the toes. A couple of other things to point out for bony anatomy. When looking at the lateral aspect of the foot, it's important to understand where the base of the 5th metatarsal is as a relevant point of anatomy. Important to understand the shape and contour of the calcaneus and to understand how it articulates with the talus, as this joint is fairly complex and less well understood by an average clinician. A couple of other things which we can barely see here and which we won't discuss after this point are the sesamoid bones of the foot. It's possible to have multiple accessory bones generally in the foot, but the sesamoids will almost always be found here, especially under the great toe. Moving on from our bony anatomy, we'll begin discussing the ligaments of the ankle. We'll begin with the lateral ligaments of the ankle. The lateral ligaments of the ankle are important to note because these are often the ones that are injured in general ankle trauma or pathology. We'll begin anteriorly with the anterior talofibular ligament. Important to keep in mind that this is the talofibular ligament and not the tibiofibular ligament, as seen here on the right image, which is a bit proximal to the anterior talofibular ligament, seen here. In any event, the anterior talofibular ligament is injured in approximately 85% of ankle sprains themselves and is one of the major sources of ankle laxity or a sense of instability that people can feel after many sprains. The calcaneofibular ligament is also often interested, originating on the fibular head and inserting into the calcaneus. This is better assessed by a Taylor tilt test, but these two ligaments on the lateral aspect, the anterior talofibular ligament and the calcaneofibular ligament, are the two major ligaments which will be injured in the ankle in lateral ankle sprains. The posterior talofibular ligament seen here is a less clinically relevant ligament, though important to know where it is. Looking more generally at the ligamentous structures of the ankle, we will see the superior and inferior retinaculums of the peroneal tendons, which we can see here are cut. We'll discuss this a little bit more once we actually get into the tendon structures of the ankle, but important to be able to see them here. We also see the Achilles tendon inserting here, and we have a view at this point of the posterior and anterior tibiofibular ligaments. I'll bring these ligaments up briefly here again, but we will be talking about them when we move on to the medial ligaments again in a second and to the anterior ligaments. But when looking at the lateral ligaments, the reason that these ligaments are important is because these two ligaments are two of three components of the syndesmosis of the ankle. The syndesmosis of the ankle is the ligamentous complex which provides stability across the ankle mortise. In other words, these ligaments prevent the splay or separation of the fibula and tibia as weight is borne across the ankle. When these ligaments are disrupted, we often see that the ankle will be predisposed to pain and arthritis as the talar dome is no longer well maintained. I'll point this out again when we get to the anterior ligaments and view of the ankle. One final thing to be visualized on this slide here on the right are the multitude of ligamentous connections between the intrinsic bones of the foot. We see the metatarsal connections here, as well as the various cuneiform and cuboid, navicular, talus, and calcaneal ligaments. What these do in general is to provide a primarily rigid structure for the foot, such that weight can be transmitted or translated across the foot without major disruption or separation of these bones. However, when these ligaments become damaged, this can predispose a person to foot pain or ankle pain, and it's important to understand that these bones have normal positions from one another, which should be checked on imaging with continued pain after injury. Moving on to the medial ligaments of the ankle. The major medial ligament that we'll discuss is the deltoid ligament. The deltoid ligament is often talked about as a singular ligament. However, it really has four major components of the tibiotalar, tibiocalcaneal, and tibionavicular ligaments. These ligaments provide medial tension and structure to the ankle. The deltoid ligament is clinically relevant, though is not often injured with typical activity. The deltoid ligament is more often injured in high speed or high trauma situations with eversion or external rotation of the ankle itself. One thing to point out here is the spring ligament, which we see here connected between the sustentinaculum tali and the talus, the navicular of the foot. This ligament is relevant somewhat clinically, but is also involved mechanically for the weight bearing and more athletic movements that somebody may be doing with their foot. It has an ability to store some potential energy in it. Moving on to the anterior aspect of the ankle, this image provides a better and more intuitive view of the ankle and of the syndesmosis. Beginning again, just to point out the few structures that we've already pointed out, we'll see the anterior inferior tibiofibular ligament here, connecting the fibula and the tibia. And we see the distal portion of the interosseous membrane, which continues proximally throughout the fibula and tibial relationship or attachment. And posterior to the anterior inferior tibiofibular ligament, we would, if this were removed, see the posterior ligament, which is better visualized here on the posterior aspect of this. Moving on, we again see the visualization of the deltoid ligament here, as well as some of the intrinsic ligaments of the foot. Again, I just want to point out how important it is to understand what the syndesmosis is and how this can be relevant clinically. If we lose the structure of the interosseous membrane and the anterior inferior tibiofibular ligament, we'll begin to have the fibula splay laterally outward, which will cause a collapse of the joint. Again, this is a very important issue to be aware of and often requires surgery when injured in a major way. This, of course, is also what a high ankle sprain is, and that's partly why that's so emphasized and important to understand. Moving on from here, we'll discuss the tendons of the foot and ankle. Beginning on the lateral side, I'm going to point out again the retinaculum of the peroneal tendons. Here we see the superior and inferior tendons. The peroneal brevis and longus tendons help with eversion and external rotation of the foot. The brevis inserts, of course, into the base of the fifth metatarsal, whereas the peroneal longus continues into the midfoot underneath. The peroneal brevis tendon, when avulsed off the fifth metatarsal, is often seen as a fracture which will at times require surgery and is important to understand as a mechanism of injury. Otherwise, I would just point out the Achilles tendon once more and move on to the medial tendon structures of the foot. The medial tendon structures are a bit busier, but if we go through them slowly, should be well understood. What we will begin to see if we begin posteriorly, of course, is the Achilles tendon again, and we catch the edge of the soleus muscle here. Just anterior to that, we see the muscle belly and tendon of the flexor hallucis longus. The hallucis brevis, of course, is the intrinsic muscle which is actually very deep to the foot and found here. The longus, however, will insert into the distal aspect of the great toe. We can see that this, of course, courses now underneath, and I'll just do this slowly one time just so that everybody can see that cross as it comes forward. Anterior to that, we have the posterior tibialis, or the posterior tibial tendon. This is responsible for some dorsiflexion of the foot, as well as some internal rotation, and this tendon inserts into the inferior and medial aspect of the navicular and a little bit into the medial cuneiform, though the fibers are not shown connecting here. And then finally, anterior to that, we have the tibialis anterior, or the anterior tibial tendon, which is responsible for dorsiflexion of the foot, and will insert into the base of the first metatarsal, as well as the distal aspect of the medial cuneiform. To back up for one moment, the posterior tibial tendon, which we are seeing here, is responsible more for plantar flexion of the foot, not dorsiflexion, as I said before. Before finishing with the ankle anatomy, it's important to understand the vasculature, as these are arteries that should always be palpated when doing a physical exam. Beginning proximally in the ankle, we see the anterior tibial and posterior tibial arteries. These are main branches off of the tibial artery after it emerges from the popliteal fossa. The anterior tibial artery will become the dorsalis pedis, and this is often where we palpate the artery on the anterior or surface of the foot between the medial and middle cuneiform bones, or between the bases of the first and second metatarsal base of the first and second metatarsals. Posteriorly, we palpate the posterior tibial artery as it courses posterior to the medial malleolus. While this image does not well show it, the posterior tibial artery in fact does lie posterior to the malleolus and can be palpated there. Now, that concludes our discussion of the anatomy of the ankle and some foot. Please follow us on social media or get at us with any questions if you are interested in engaging with us more. If you like these videos, give suggestions for different videos in the future, and good luck. Thank you for your time.